Well, good morning, everybody, and welcome to another installment of our COVID-19 vaccine video series. This morning, we're going to be providing some scientific updates, responding to some of the news you've seen and some new scientific research and information. Very excited this morning to be joined again by Glenn Rall, who is the Chief Academic Officer at Fox Chase Cancer Center and the co-author of Principles of Virology, which is now in its 5th edition, a standard textbook in the field. And also Heather Klaus, who is the Senior Associate Dean for Faculty Affairs, Professor of Medicine, and the Program Director for Infectious Diseases, or for the Infectious Diseases Fellowship Program at the Lewis Katz School of Medicine at Temple University. So Glenn and Heather, thank you for joining us again. My name is Jeremy Moore. I'm a member of the COVID-19 Vaccine Communications Task Force, and let's go ahead and get started right now. Next slide. So we got two vaccines. One from Moderna and one from Pfizer. I recognize they have longer names and longer titles, but what's the difference between the Moderna and Pfizer vaccines? Is one more effective than the other?
I'm going to take a crack at this first.
Sure.
So so maybe the succinct way of putting this is that there are differences, but those differences don't matter to a vaccine recipient, right? So what are the differences? Well, one of the differences is that the dose of RNA that is present within the vaccine is slightly different. The Pfizer vaccine is 30 micrograms of RNA. The Moderna vaccine, I believe, is 100 micrograms of RNA. Those may seem like substantial differences. They, in fact, are not. They are pretty equivalent in terms of the amount of RNA that would be provided to a vaccine recipient. So that's one difference. The second difference is the period of time that needs to elapse between the first and the second dose. Heather, actually help me out on this one. For Pfizer, I think it is 3 weeks. For Moderna, it's 4 weeks, plus or minus.
Right.
That's right.
That's right. 21 days and 28 days.
Yep. And it probably is simply that's how their particular trials were established. It's not that, if by some chance you got the Moderna after 3 weeks that it's, going to inactivate the whole thing. Not at all. It's just this is how the phase 1, 2, and 3 trials were established. This is what the safety and efficacy data were predicated on, and therefore that's what's being recommended for vaccine recipients for this. So just that 1 week difference, but again, it's not really a functional difference between these. And then the only other thing for anybody who cares about this level of geekiness is that the lipid that the RNA is encased in. Remember that this is an RNA molecule that's kind of surrounded by an oil droplet that makes it particularly tasty for the cells in the arm to gobble up and synthesize the protein, are slightly different because these two companies have been developing their own RNA vaccine platforms for over a decade, and they have proprietary differences among them. But other than that, there are no other functional differences, and most importantly, there is no difference in effectivity. I get asked with some frequency, like if you had the choice, which of these would you prefer, right? And it's not like McDonald's French fries versus Burger King French fries where people have strong opinions about this. There is no difference between these two. I would accept happily either of these two.
I would agree, Glenn. The only other thing, the difference between them is their storage requirements, and I think that's a logistical thing that doesn't impact the efficacy of the vaccine. They were both equivalent in efficacy, 95%, around 95%, 94, 95. But the Pfizer vaccine requires a super deep freezer, -70, -80-degree freezer, which offers some logistical challenges for vaccine distribution. And unlike the Moderna vaccine, which is able to be stored at a traditional freezer temperature, the Moderna is additionally able to be used within 30 days after thawing, where it's only 5 days for Pfizer. So there's some logistical things that make Moderna a little easier, but they're functionally equivalent as far as I'm concerned.
So in other words, we got logistic issues for the storage and distribution, but to the end user, it's the exact same thing.
Exactly right.
Right. Importantly, safety and efficacy, both. I mean, high level of efficacy, virtually no concerns about safety for these.
Great. Let's go to the next question then. So I hear that these vaccines do not use preservatives, live virus, or eggs, standard parts of normal vaccine distribution. Is that good or bad?
I'll take a crack at that first. I mean, I think it's ultimately good. You know, we have issues with some vaccines and folks who have egg allergies, and this is not an issue for the Pfizer nor the Moderna COVID-19 vaccine. So I think that in that sense, it's good. I don't think it functionally makes the vaccine more or less effective. I think it just is an end user availability issue or availability issue. In terms of the preservatives, I would say that in theory, preservatives are another compound that someone could have an allergic reaction to or experience a side effect from, although traditionally not. So I would say the less the better, but the fact that the absence of preservatives is what it implies and causes some of the storage issues we were just talking about in terms of how labile they are and have to be used quickly.
Yep.
Glenn, anything to add?
No, other than to say all three of those are slightly different, right? The fact that it's not made in eggs is actually quite good because, as Heather points out, people can have egg allergies. Preservatives are just more things that go in there. I think we tend to think, well, things that have preservatives are somehow a little bit more artificial or contrived. There are some vaccines that do contain preservatives and are still also perfectly safe. But I think, if I had my pick, I'd rather have them without preservatives, as long as they're still effective. The live virus one is actually interesting because there are vaccines, not this one, but there are vaccines that are live viruses, and they are also effective and they are also safe. So I don't want to say that it's good that it isn't live virus as a kind of backhanded way of dissing live virus vaccines. There are ones that are quite effective, but I think the point about this is that these vaccines, these two RNA vaccines, are as pared down and as simple and as almost elegant as you can get for a vaccine in terms of the simplicity of the delivery and also the stuff that is, sort of part of the packaging with them. So overall, I think that simplicity is a good thing.
And I would say that the fact that it's not using live virus does enable folks who are immunosuppressed to be able to have the vaccine. So
Right.
I think in that sense, it's good because it expands the pool of folks who can access the vaccine safely.
And also pregnant women, right? We don't use live virus vaccines like the MMR in women where at least it's not recommended for women who are pregnant. That's correct, isn't it, Heather?
That's correct, yes.
Right. So it expands then the opportunity of folks, or the spectrum of folks who can have access to this vaccine.
Great. Next question. So talked a little bit about this already, but what are the side effect profiles of these vaccines? And have we seen, without releasing private patient information, have we seen any concerning reactions at our locations?
Heather, do you want to do that one?
Sure. So as Glenn mentioned, the side effect profiles are really very similar between the two vaccines. With the Pfizer vaccine and actually with the Moderna vaccine, the most common side effect was local pain, redness, arm soreness, things like that. And that happened more often than it didn't with both vaccines. A little bit more often after the second dose of both vaccines. In terms of other more systemic side effects that have been reported in the trials with each vaccine have been fatigue, headaches, muscle aches, some joint pain, fever, and those were increased after the second dose, or more common, I should say, after the second dose of each vaccine. But they occurred on the order of the fatigue was about 60%, headache maybe 50%, fever around 5% after the first dose, and up to about 10% to 15% after the second dose. So really, in ascending order of things that would be bothersome to a person, the decrease, there's a decrease in the incidence of those things like, severe fever and things. I would add at our local sites, we haven't seen any anaphylaxis. That's the first and foremost most important thing. I know there was some conversation about anaphylaxis in particular with the Pfizer vaccine, because in the UK and even in the United States, in the first couple of days of rollout, there were a couple cases of anaphylaxis. We have not seen anything severe in that way at our Temple sites. There have been a handful of folks who have reported to the COVID exposure response team, which is a Temple unique entity, a few reactions: swollen lymph nodes, nausea, fatigue, headaches, things like that. Not that those things aren't uncomfortable, but we don't consider them to be limiting to get your second dose.
Just two little addenda to this. So the anaphylaxis, which people, I hear these vaccines could cause this, as Heather points out, no different from other vaccines. And if there was going to be an anaphylactic or an anaphylactoid reaction, it would occur within minutes after exposure. And this is the reason why, after you get your vaccine, you're not just sent back out into the world, but you're asked to sort of, plunk yourself down in a seat and you're watched for about 10 or 15 minutes. And that services are available if on the really, really, really rare chance that somebody was having a reaction, we would be able to take care of you. So this is not something that would occur after you've, left the room and left the building. This would be immediately afterward. Only other point is, if you have body aches or low-grade fever or, whatever else, it's okay to take a naproxen or take some Advil. It's not going to do any damage or any harm, and it will be transient. And it is, in some way, you can look at it, even if you don't feel comfortable, you can say, well, this is proof that my body's immune response is working. That's the reason why the second vaccine often has a little bit more of an accelerated chance, because your immune response has already been primed to the vaccine. So it's, coming back with even more gusto. It's a good indication that you're protected.
That's exactly right. And I would add that we don't recommend prophylactic, meaning
Right.
before the vaccine medication with the NSAIDs, Advil, naproxen, et cetera, or Tylenol. But if you do have side effects, as Glenn pointed out, muscle pain or joint pain or fever, you can take symptomatic relief with Tylenol or NSAIDs.
All right, great, thanks. Next question. Okay, so building on the question of reactions, are there any reactions that would cause me as a vaccine recipient to need to miss the second booster dose of the vaccine? Like something that I should be on the lookout for that would prevent the second dose?
Glenn, do you want to take that first?
Well, my temptation, actually, I'm kind of curious what you think on this, Heather. My temptation would be that unless you had a severe reaction to the vaccine, some sort of allergic response to this, if you happen to have an anaphylactic or anaphylactoid reaction to this, but it would be something notable that would perhaps cause you to miss the second dose. But other than that, I don't think that there probably are a lot of other things that would cause you to miss it. I guess perhaps if in between your first and second dose you test positive for coronavirus, that would be a conversation that would be worth having to defer getting your second dose, not because the second dose would do anything bad for you. It just wouldn't be as effective if your body is already fighting the infection itself. Putting this in on top of it is just adding a little bit of extra noise. But other than that, I don't think that there's anything else. Is there, Heather?
No, I think that's exactly right. I mean, I think severe allergic reaction, anaphylaxis, or slightly less allergic reaction than anaphylaxis, I think is the only contraindication to the second dose. And I think in a future question, we can talk about the timing of the vaccine if you were to happen to have symptomatic coronavirus infection in between your two doses.
Let's go to the next question. So we have other vaccines in development. We've seen this in the news, one from AstraZeneca, one from J&J. They don't use the messenger RNA. Are these vaccines better? Should I wait for them?
I can do this one. No,
Okay.
And no. There. How's that? Is that good? I mean, in the sense that there are other vaccines that are coming out, and at least we think that there are. There are ones that are certainly moving forward in development. They have not yet received FDA emergency use authorizations yet. We're hopeful that they will, but they haven't yet. And that requires the FDA to assess the data that we've collected so far and determine if, like the two that are available, they're safe and effective and all the rest. All the data that we have so far indicates that they are safe and effective, as much so as the Pfizer and the Moderna vaccines. So they are different, but they're not necessarily better. Maybe I've done it on this video, but there's a metaphor that I use that I think is relevant. There's lots of different ways to get, have I used this already, Jeremy? To get from Philadelphia to New York City.
I like this one though. You can do it again.
I'm glad you like it. Right, you can take I-95, you can take a back road. But ultimately, the destination is the same. We're all getting to New York, regardless of the path that we take. So all of these vaccines are intended to do the same thing, induce immunity to actually a particular protein of the SARS coronavirus, the spike protein. So their formulations are different. Maybe if these get EUAs in a future one of these meetings, Heather or me or others can talk about how they're different, but it certainly shouldn't be something that you wait for. And this, I think, is important, right? When that balloon passes over, you know, you want to grab it. You want to, if you're willing to get the vaccine, you want to be able to get it when you do and not say, well, that one's yellow and I'm going to wait for an orange balloon to pass by, because we're going to get into a case where there's going to be a supply and demand challenge here. So when you're offered this vaccine, if you are of the mind to get it, and we understand, and this is why it is not mandated, that there might be some people who choose not to get it, but if you want to get it, there is no reason for you to wait for something better coming down the road. I don't know how much better you get than 95% effective with 0% challenges or side effects for this.
I totally agree with that. I mean, I would say that the best vaccine for coronavirus is the vaccine that's in your arm. And so, you know, whichever you can get, you should get. And AstraZeneca's vaccine, the Oxford AstraZeneca vaccine, has been approved in the UK. They haven't presented their data to the FDA, as Glenn alluded to, so they don't have an emergency use authorization in the United States. Their efficacy looked a little lower than the Pfizer and Moderna. I don't think it's super significantly so, but we don't know until we review the data ourselves. The Johnson & Johnson vaccine trial, as you know, Temple was a site for that, one of the largest recruiting sites in the world, actually. And so some of our staff and faculty and physicians and everyone were able to participate and either get placebo or the vaccine product. They're going through the emergency use authorization, they predict in early February. So they're like finalizing their follow-up data and hopefully presenting to the FDA in early February. So I would look for the next sort of news about a new vaccine in the United States, at least Johnson & Johnson's, in early February, if all goes well for them. And so at that time, we can maybe do another one of these and comment more on their data and how it compares to Pfizer and Moderna. But for now, grab the balloon, get it in your arm. Let's do it.
Take I-95 rather than the turnpike.
Take I-95, the fastest way. Take the Acela. Take as fast as you can get there.
Absolutely. Next question. So this has been in the news a lot. I heard there's a new virus mutation. I'm hoping that we can hear a little bit about what does that mean, mutation, and would that affect vaccine efficacy?
Glenn, I'm throwing the viral genetics to you.
So I think the word, all right, let's back this up, but this won't take long. The word mutation is scary, right? You know, any of us, so I'm 57 years old, I remember the, you know, Creature Features when I was a kid, and, you know, the mutant that climbs out of the swamp. This is when we hear the word mutant, this is what I think comes to mind for a lot of folks. And then there's also mutations that, for example, that we associate with cancer, where you have, you know, very impactful genetic changes that might predispose you to getting certain cancers. In the field of virology, mutations are expected. There is no virologist or infectious disease person worth her salt or his salt that is going to be in any way surprised that there are variants of this coronavirus that come out. These mutations, generally speaking, refer to nucleotide changes in the genetics, the RNA that this virus uses to, you know, that is the genetic code for this virus. So a mutation is simply going from an A to a G or a C to a T. It may not have any consequence whatsoever on the ability of the virus to replicate. In most cases, it actually, mutations kill the ability of the virus to mutate. And in very, very rare circumstances, it makes the virus more fit, more able to spread from person to person. So with that bit of background, yeah, there is a new virus mutation. It's prevalent in England. It's now in the United States. And I guarantee that you will see in the Philadelphia Inquirer, or, you know, whatever your news media of choice, you're going to give it a month, maybe less, that, you know, the variant is in Philadelphia, and everybody's going to be like freaking out because the swamp monster is here. No, it's not that big a deal. It may be, we don't know for certain, but it may be associated with increased transmissibility. That means an individual that has this variant may be able to spread it more effectively to other people. But the good news, two pieces of good news, are first, that it doesn't cause a different menu of disease. The disease that you get with this variant is identical to the disease that is caused by the parent virus, which fortunately for the vast majority of individuals is fairly mild. And better still, all of the vaccines that have been developed, the Moderna and the Pfizer, plus the few that are on their way, as Heather pointed out, all are predicted to be efficacious against the variant, this viral mutation carrying virus, as they are against the parent strain. So there's nothing you can do about it. I mean, if you want to get scared about it, I can't tell you not to get scared about it, but frankly, your behaviors shouldn't change. It still is about masks. It still is about keeping your distance. It still is about washing your hands. And it still is about getting your vaccine. That's how you move beyond this virus and all of its mutations.
The only other thing I would add about that is I just wanted to let everyone know that the lab equipment used at Temple and at Fox Chase is able to detect this variant.
Yep.
So it's not that you're going to be sick with this variant, or a patient that you are taking care of is going to be sick with this variant, and that coronavirus test is going to be negative, and you're going to wonder, gee, is this the variant that's in England that I'm just not seeing? Our lab has confirmed that they pick it up with our current equipment. All the turnaround time tests, there's a couple different machines that we run these tests on, they all detect the variant virus, so that's great. And I would just say that the other thing that sounds scary is that the mutations that they describe in this variant in the UK are at the spike protein area. So there's probably have been a lot of mutations over the time that this virus has been here in the last 10 months. But the one that is of concern in England is that it's at the spike protein. And since the vaccines attack or are formed based on the spike protein, that's, I think, some of the reason for even increased concern over a normal mutation concern. But I agree with everything Glenn said, that the vaccine should prevent either type, wild type or this variant.
Can I actually because there's maybe a scientific follow-up to this that I think might provide a little bit of reassurance, because Heather's right. I think, some of the mutations, because it's multiple that are in these, I think it's like 32, 33 different mutations. Some of them do occur within the spike protein, and that makes people anxious because that's the target for vaccine. So Jeremy, with your permission, can I do a demo of something?
Absolutely, you got props.
So, I got a prop, which is just a piece of paper. I don't even know what it is, but a protein, let me show you, see if this works. You might laugh at me. A protein looks like this, right? It's this kind of very complex three-dimensional torsional structure. The neutralizing antibodies that we're trying to gain with the vaccine recognize sort of little nooks and crannies and corners of this three-dimensional spike protein. So if a mutation knocks out one of these, like if I were to snip off just a side of this, there still is all of these other epitopes or all of these other parts of this protein that can be recognized. And we predict that there are somewhere north of 20 different sites on the spike protein surface that antibodies are able to recognize. So even if there is a mutation that might ablate the ability of 1/20th of your neutralizing antibodies to recognize it, don't fear, because 19/20ths of that protein and those epitopes are still available for the spike or for the antibodies to bind to. So
great demonstration. I like
Yeah,
it.
you like this?
Really good. We don't need CGI or anything on these calls. We got crinkled paper and Glenn Wall's compelling personality.
High tech.
All right, let's go to the next question. As vaccine, okay, this is the spicy one, especially for those who may have a problem wearing their masks and so forth. As vaccine administration continues, what precautions are still reasonable to take? Masks, social distancing, et cetera. I mean, I think probably there may be some reaction. You got the vaccine, we're done, we can go back to normal. Can we spend some time just reiterating what we should be doing?
Sure. Let me take the first swing at that. The first thing I want to say is that the vaccines, the Pfizer and Moderna vaccines, have been shown their efficacy was to prevent coronavirus disease, meaning symptomatic infection, and severe coronavirus disease. And we don't know if it prevents asymptomatic infection or carriage or whatever word you like to use. And so the fact of the matter is that once you're vaccinated, you may feel safer, like mentally, and you may actually be safer from severe coronavirus disease and from coronavirus disease. But you may still be a carrier and you may still transmit it to your patients, to your friends, to your family, to your loved ones. And so we unfortunately are not at a point where we can stop using masks. You must wear your mask at Temple all the time. If you're in the building, if you're outside, you need to wear your mask. You need to stay 6 feet apart. All of those things still apply. I understand that you feel safer, and I am so happy that all of us are going to be safer, and many have been offered the vaccine, and all of us will be eventually at Temple. But I just need us to wear the masks, stay apart, be careful in the break rooms. All the precautions we've had in place this whole time don't change yet. I'm not saying never. I'm not saying we have to live like this for the next 20 years, but for the next few months at least, and we will keep updating these videos and the precautions as they are safe to lighten up, we will. That's my 2 cents.
Glenn?
Yeah, I'm going to be a little meaner than Heather on this one. Right. So let's put aside the whimsy of rolling up paper and actually talking about how we see our way through to the end of this pandemic. I get it that you're all tired of this. Believe me, Heather, Jeremy, others who've been doing this for 9 months, we are too. And that there was something about the turn of the calendar page, you know, fresh year and being able to put 2020 behind us, and we are ready for this thing to be finished. And I get it, that's true. But over the next couple of months, we're going to be living in this parallel universe. On the one hand, yes, these vaccines are out, they're deployable, and a lot of folks who are in healthcare organizations are top of the list to be able to get them. How lucky we are that we're at the top of that pile. But at the same time, thousands of Americans are dying every single day. I keep this ghoulish Excel spreadsheet every single day. And just between Tuesday and Wednesday, 3,300 Americans lost their lives, died of this thing. So it isn't over just because 2020 is over. And it is irresponsible to not take care of yourself when you are when you're doing your job in the health system or here at the cancer center. It's irresponsible to not do it when you're out in public either, but we can't control that. But bear in mind that you are putting, when you don't wear your mask or when you're sloppy about your mask wearing, or when you're sort of like, yeah, that doesn't really matter very much, you're putting not just the lives of our patients at risk, but also of your colleagues, the very people that you work most closely with. So snap out of it. I know they're uncomfortable. I know you don't like them. If you want to yell at somebody, send me a nasty email, but wear your mask, because you can still Charlie Brown football this thing in the very, very final steps. And it is not okay for folks to be walking around cavalier about the very thing that works the best to protect us from each other.
Well said from both of you. I think we'll just leave it there and go right to the next question. If I've had a COVID-19 infection, should I get the vaccine? And if yes, how long should I wait to get vaccinated? Heather, I think you alluded to this a little bit earlier, like how actually getting infection affects the vaccine pace. So why don't you go ahead and go first?
Sure. So the first thing that I'll say is that we think that most people who have natural infection get sick with coronavirus 19 or SARS-CoV-2 get antibodies that last for 60 to 90 days. And we think that the reinfection risk, the risk that you catch it again in that 90-day window, is very low. So the CDC has some guidance that basically says those folks who have had SARS-CoV-2 infection can defer the vaccine up to 90 days, but not forever. It's not like chickenpox. Once you've had chickenpox, you don't ever need the vaccine. It's not that. So you will need the vaccine, definitely, whether you've had it or had the disease or not. The timing of it, I think, is a little, the guidance is a little vague, in my opinion, and there's some discrepancy, I would say, and confusion, and that leads to a lot of discrepancy and confusion about from others. I think that, again, when you're offered the vaccine, if you are not currently symptomatic from your disease, if you are out of your quarantine period, so if you're 14 days past your positive test and your symptoms have gone away, it is safe for you to get the vaccine. So anytime in that range from 14 days following your positive test to, let's back it up a little, before 90, maybe, just for my sanity, but you should get the vaccine during that window. And if there's other extenuating factors, then you can push it to later in that window, or you really are anxious and want to get it sooner, earlier in that window. We are so fortunate, as Glenn pointed out, to even be having this conversation, because no one is able to get this vaccine yet right now in the public, except for healthcare workers, almost. So, I mean, I would say get the vaccine when you can. The other thing I alluded to earlier, Jeremy, was, there's been some reports in the media of folks getting their first dose of the Pfizer or Moderna vaccine, and then, say, 7 days later, 10 days later, getting symptomatic COVID disease. And in those folks, that does not mean the first dose failed. That probably means you were exposed before you got the vaccine, or in the first few days before the vaccine really started revving up your antibody protection. And that's why you're having symptoms. For the second dose, you have to wait till after you're out of the quarantine period, but you don't have to defer those 90 days. I think my understanding of the recommendations is that you should still get it as close to the, prescribed interval, 21 days for Pfizer or 28 days for Moderna, as you can, assuming you're not symptomatic, assuming you're not critically ill, and assuming that you're out of your quarantine period where you're not going to infect the folks who are giving you the vaccine and serving in that way.
Glenn, anything to add to that?
Nope, that was perfect. Nothing.
I thought so too. And last question, if I've had Bell's palsy, can I get the vaccine? Heather, I think this one is for you too, talking about a specific side effect.
Sure. So in the two clinical trials, in the Pfizer trial, there were 4 cases of Bell's palsy in the vaccine arm and 0 in the placebo arm. In the Moderna trial, there were 3 cases of Bell's palsy in the vaccine arm and 1 case in the placebo arm. Again, there's 20,000+ people in each arm, basically. And so I haven't heard of Bell's palsy cases happening, A, at Temple, or B, even as the vaccines rolled out. But if you've had prior Bell's palsy, that is not a contraindication to getting the vaccine. You should get it. You should definitely get it. The only contraindications, as we talked about, are history of severe allergic reaction or anaphylaxis to vaccine components, or potentially have a conversation with your doctor if you've had anaphylaxis to other intravenous or injectable medications. But there's not a disease contraindication. Pregnancy is not a contraindication. Breastfeeding is not a contraindication. Not that those are disease states, but other, immunosuppressing disease states are not contraindications to getting this vaccine, including Bell's palsy.
Well, I believe that brings us to the end of our questions. So it remains for me to thank our panelists for coming back again. Glenn and Heather, it's always a great pleasure and privilege to have you here and educate our community. Quick programming note, we're going to be doing another one of these very soon that's going to deal with the details of the vaccine rollout and administration, and where you can sign up and so forth. That'll have Tony Reed, our Chief Medical Officer, and Dwight McBee, our Chief of Patient Experience. So be on the lookout for that in the next couple of days. But for now, thank you to the panelists. Thank you to the audience for hanging in, and we'll be back again real soon. Thanks, everybody.